Today, inshallah, we'll discuss approach to hemiplegic case of hemiplegia. Just let me to remind you firstly about the anatomy of the corticospinal tract, just to remind you, because mainly the hemiplegia, there is affection of corticospinal tract, which is the pyramidal tract. As we mentioned before, that pyramidal tract is the one responsible for transmission of the motor order from the brain, higher cortical motor area, till reach down to the muscle to make the movement. So, pyramidal tract is started from the cortical motor area, then go down through the internal capsule, then to the brain stem, starting from midbrain, bones, medulla. Then at the medulla, there is medullary decussation, and it will cross to the opposite side, go inside the spinal cord till they lie here in the anterior horn cell. Then from the anterior horn cell, via the ventral root of the spinal cord, reaching as a peripheral nerve, then to the muscle for the action through the neuromuscular junction here. So the cortical area on the left side is responsible for the movement of the contralateral side, I mean the right side of the body, and vice versa. The cortical area of the right side of the brain is responsible for the motor side of the left side of the body. Then as we mentioned before, regarding the any lesion which will affect this, any lesion will affect the blue line, i.e. from the cortical area till the anterior horn cell. This any lesion in this pathway will lead to upper motor neuron lesion manifestation, while any lesion will affect the and from anterior horn cell downward through the nerve and muscle and neuromuscular junction will be manifested as a picture of lower motor neuron lesion. Let's go now to what we will need to examine in case of hemiplegia. As the routine sequence of order of examination, we'll check the if we would like to screen the patient to check which limbs is affected, asking the patient to raise the upper limbs and lower limbs, we'll find that there is one side of the body. There is one side of the body is affected. So this is called that there is right side weakness of the in the upper limb and lower limb. We will check the same sequence as we mentioned before: tone, power, reflexes, coordination, and sensation. In the each one will examine in the upper limb and the lower limb. Regarding the motor action, we'll check the tone, then the power, then the reflexes. Okay, in lower limb, then in upper limb, for example. Then after that, we'll check the after tone, power, reflexes. We'll go to the coordination, also in the upper limb and lower limb. I don't know how this happened. Then after that, the go to the sensation, all modality of the sensation to be examined, like the pinprick sensation and the touch sensation by the cotton and the vibration sense and sense of position. Then don't forget to check the cranial nerves. Especially there is representative nerve we can mention like this for each part of the brain stem, especially in midbrain, bones, and medulla. As we know, in midbrain, the third nerve, oculomotor nerve, will be the representative if any affection in the midbrain. In bones, the seventh cranial nerve, the facial nerve, and in the medulla, the hypoglossal nerve. So, if you have a case of hemiplegia and we find a cranial nerve affection, this will give us a clue for two things. Number one, there is a brainstem affection. Number two, which area of brainstem is affected. If you find the facial nerve is affected, so we'll think about bones, and if oculomotor, we'll think about midbrain. If hypoglossal, it will be medulla. If 2 or 3 like this, so it will be the lesion affecting many part of this. Also in cranial nerve affection, we need also to check what is if there is any bulbar symptom affection or no, like checking the speech of the patient, swallowing capability, if he can swallow or there is any difficulty of swallowing, or this patient is liable for aspiration, for example, and the gag reflex, is it intact or no. This is to much extent is important in a real clinical scenario rather than in exam, but we need to put it in our minds. Don't forget to check the eye for nystagmus or any associated cerebellar lesion. After that, the most important also is the gait of the patient. Don't forget to examine the gait of the patient, and we will mention if this case is hemiplegia in shock stage, so there will be paraparesis and the patient cannot stand well. Okay, but if this old hemiplegia or old stroke, there will be a rigidity and the leg will be extended, so the patient will have the characteristic circumduction gait in the lower limb, and in the upper limb of if long-standing hemiplegia, there is a flexion attitude in the upper limbs and extension in the lower limb with the characteristic circumduction. For sure, kindly note that the heart or the cardiovascular examination is very essential in any case of hemiplegia, because as we know that there is a cardioembolic or cardiothrombotic lesions can lead to hemiplegia, especially if this patient has atrial fibrillation or have any carotid dissection or have any cardiac intramural thrombus, etc. So do not forget to examine the cardiovascular system to check it is intact by clinical methods as well as by the investigations, as we mentioned later. From the clinical point of view, check the pulse, is it regular or no, and this is very important rather than the counting of the pulse, the regularity, to rule out any arrhythmia or any atrial fibrillation, and auscultate the heart, check any murmur associated or any valvular lesion. Also to check the carotid regarding any associated carotid bruit to rule out any abnormality in the carotid. Let's go to the steps of examination again by another way. We will examine like the following. We'll examine the upper limb and lower limbs. In upper limb, we'll check the affection in the form of upper motor neuron lesion in with each all characteristic signs like hypertonia, hyperreflexia, like this, and don't forget what's called pronator drift. This is usually be present, especially in the acute stage of stroke. You might face this in the emergency room as well. And it is used even by the paramedics cases. When you ask the patient to make his arms extended, you will find make the patient arms to be extended, and these extended arms, you ask the patient to put it in a supination position. Supination, I mean that the palm is facing the seal. You will find that the weak limb will be started to do a pronation, semi-pronation movement will be appear. Okay. Then examination of the lower limb. You will see also the characteristic features of the upper motor neuron lesion in the form of, as we mentioned before, hypertonia, hyperreflexia, upgoing plantar reflex, Babinski sign, plus or minus other signs like clonus, like pathological reflexes as patellar reflex or abductor reflex. And also the characteristic weakness pattern, as we mentioned, that the in lower limb, you will find that the weakness of the muscle will be in the distal muscles. Distals are weaker than proximal, flexors are weaker than extensors, and the abductors are weaker than adductors. Okay. After that, check the cranial nerves, as we mentioned before. Cranial nerves is a clue for brainstem affection. Usually, check the, as we mentioned, third facial hypoglossal, but we may be concerned more, especially in the facial nerve, the 7th cranial nerve, and hypoglossal nerve, the 12th cranial nerve. regarding any facial drop, and if this facial affection is it in all the face or in the lower part of the face. We will discuss this later. Also, the tongue regarding any deviation of the tongue. Okay. Don't forget to check the speech regarding any disarticulation or dysphagia. And usually, this dysphagia appear in affection of the dominant hemisphere. Okay. Usually, in patient right-handed, there is a dominant hemisphere of the left side. If there is affection of Broca's area, that will lead to what's called motor dysphagia. Motor dysphagia, another thing, is expressive, that the patient cannot express themselves, cannot articulate the words well, so it appears as a non-fluent in speaking. The opposite is if there is affection of the vernix area, which is responsible for the sensory dysphagia, the result in a sensory dysphagia, so the patient cannot receive there's a problem in receptive, so it is called receptive dysphagia. So it is the same name, sensory dysphagia, receptive dysphagia, or vernix area affection. In Broca's area, it's called motor dysphagia or expressive dysphagia. The patient will be non-fluent because the motor system is affection, but in sensory, the articulation can be done with the motor. After that, as we mentioned, the gait is very important, which is called circumduction gait, and or sometimes scissoring, because if you have patient has bilateral lower limb weakness in the form of upper motor neuron lesion, it's called scissoring. So if one limb only, like this case in case of hemiplegia, it's called a uni-scissoring gait. Remember that I'm speaking here about the long-standing case of hemiplegia, the patient with long-standing stroke before, like you see a patient for many years like this. But in case of acute hemiplegia, what you can see in emergency rooms, usually there is a shock stage or what's called flaccid hemiplegia. Okay. Let's elaborate more also regarding the hemiplegia. Usually in hemiplegia, as you know before, there is what's called fast screen, usually done by the paramedics and the ambulance staff, which is abbreviation of the fast face, the face, and the arm, and speech and time. The face, if there's any facial drop or any abnormality in the one side of the face, if it's in the all one side or it is lower part of the face, we will discuss this in details. But the face affection, the arm, which is weakness in the arm, patient cannot stand his arm straight for sometimes, and there is a pronator sign. The speech, if there is any abnormality in speech, okay, the time is the time of onset, because it's very important in case of ischemic cerebrovascular stroke, because a patient with an ischemic cerebrovascular stroke and in a window phase, which is 4.5 hours from the onset of the stroke, and this patient has a normal CT, i.e. without any intracerebral hemorrhage, the cerebral hemorrhage is excluded by the primary initial CT brain, and he fulfilling the criteria of receiving the thrombolytic therapy, and there is no any absolute or relative contraindication, so we can consider the thrombolytic therapy in this patient. Okay, this is important of the time. Okay, let's go to the site of lesions in case of hemiplegia. It might be there is an affection in the cortical area, the motor cortical area, or in the internal capsule, or there is maybe a cranial nerve affection. If the hemiplegia affecting the cortical area, it will depend on the surface area of affection in this cortical area. If it is large cortical area affection, so definitely it will affect the cognitive functions, the conscious of the patient. The patient may be in a coma or cannot do a cognitive function well. Aphasia might occur due to affection of Broca's area and the vernix area, as we mentioned before. Convulsions due to affection of large area of the cortex, or monoparesis if there is a specific location in a specific part of the body is affected, or if there is an internal capsule affection, as we mentioned before, in the busway of the pyramidal tract. The internal capsule, if it's affected, it will lead to contralateral side of the body motor affection. Okay, because the pyramidal tract is path from the cortical area till the medulla, till the end of the brainstem, then it starts to decussate below at the level of medulla. So any affection in the internal capsule, it will lead to a contralateral side of the body affection. Let's go to the issue of cranial nerves affection. The cranial nerves affection, usually we are checking the facial and the hypoglossal nerve and compare the site of affection of the cranial nerves with the site of affection of the body. Okay, to make it easy, the lesion which will affect the brainstem, it usually affects the pyramidal tract. Okay, and the brainstem in this place, the pyramidal tract will be manifested as contralateral side of the body affection, while the lesion in the brainstem will be at the level of the nucleus of the cranial nerve, so it will lead to what's called lower motor neuron lesion of the cranial nerves. So at this lesion, there is affection of the body in one side and the contralateral affection of the cranial nerves. That's what called crossed hemiplegia. So crossed hemiplegia, it means the lesion manifested by cranial nerves in one side of the body and the body affection in the other side. Okay, it's called crossed hemiplegia. But if the case affection in the internal capsule, the body affection will be in the contralateral side of the internal capsule, but the cranial nerve affection will be in the same side of the body affection, and it can be called as uncrossed hemiplegia, or previously named as uncrossed hemiplegia. Also, do not forget regarding the sensory loss, if we have a spinal cord affection above the level of C5, so there is a lesion in the upper limb and the lower limb because we are above the C5, and if there is a hemisection of the spinal cord, it will lead to what's called Brown-Sequard syndrome. Brown-Sequard syndrome, just in summary, we making a cut of the spinal cord, like by trauma or by imagining that I have a hemisection of the spinal cord. For example, we cut the spinal cord at the level of T8. This is the spinal cord. We make injury of this hemisection of the spinal cord. The main tracts here is the pyramidal tract and the lateral spinothalamic tract, and this is the dorsal column. Okay, affection here, as you know, it will affect the pyramidal tract in the same body, so upper motor neuron lesion will appear in this body, as well as the dorsal column. It also will be impaired in the same ipsilateral side of the lesion of the spinal cord in the form of loss of vibration sense and loss of position and sense of position and proprioception. And there is opposite side or contralateral affection regarding the sensation of pain and temperature of the contralateral side, because there is affection here of the decussation of the lateral spinothalamic tract, which come from the opposite side here. Okay, so it will be affected if there is a lesion in the hemisection of the spinal cord at this site. So Brown-Sequard syndrome, there is pyramidal tract affection of the same side, ipsilateral pyramidal tract affection, ipsilateral dorsal column affection, contralateral loss of pain and temperature. Coming to the levels of hemiplegia, as we mentioned, just to make a summary again. If there's cortical affection, there will affect to coma or aphasia, or especially if there is affection of the middle cerebral artery, which covering the lateral part aspect of the brain, the temporal and the parietal area. If there is lesion in the capsular area, in the internal capsule, there will be what's called affection of the cranial nerves of the same side of the body affection. So cranial nerve number 7 and 12 will be affected in the same side of the body affection. Okay, and the body, because to compare this with the brainstem affection. In brainstem affection, there is hemiplegia in one side and contralateral affection of the cranial nerves. Okay. And lastly, the spinal cord affection above C5, as we mentioned, for the Brown-Sequard syndrome. There's ipsilateral upper motor neuron lesion and dorsal column affection with contralateral loss of pain and temperature of the opposite side of the body. Again, by another algorithm, I am trying to emphasize on the same information just to make it easy for you. Same levels of hemiplegia, cortical area, capsule in the internal capsule, brainstem affection, either midbrain bone, medulla, spinal cord lesion above the C5. Then the checking of the sensation. What about sensory affection in the case of hemiplegia? If you have an intact sensation, go direct to check the cranial nervous affection, especially 7 and 12, as we mentioned before. If the cranial nerve affection coming in the opposite side of the body, it's called crossed hemiplegia. I mean, there is upper motor neuron lesion in one side of the body, and there is cranial nerve affection on the opposite side of the body. This is called crossed hemiplegia. Or it may be affected in the same side of the body, so upper motor neuron lesion in one side of the body, plus cranial nerve affection in the same side of the body. If there is sensory affection, it may be either the internal capsule is affected, which will lead to a hemisensory loss, or there is a spinal cord affection above the level of C5, leading to what's called hemisection of the spinal cord or Brown-Sequard syndromes, ipsilateral pyramidal and dorsal column affection, plus contralateral loss of the pain and temperature. Now let's go in details regarding the cranial nerve affection, especially in case of hemiplegia. We'll try to emphasize upon the facial nerve, especially. This is a simple diagram. I'd like to simple diagram to make it more easy. This patient has a lesion here in the brainstem of the left side. Okay, so definitely the pyramidal tract will be affected in the brainstem, so it is still in the upper part from the cortical area to the medulla, so it will reflect it to affection of the opposite side of the body. So this patient will have a contralateral side upper motor neuron lesion. Plus, due to the affection of brainstem here, especially if it comes to the facial nuclei, which is located in the bones, it will lead to a lower motor neuron lesion of the facial nerve, which will be manifested as a hemifacial affection of the muscle of the face in left side of the body. Okay, so that's what I'd like to illustrate for you. What's called crossed hemiplegia means that one side of the body affected and the other side of cranial nerve affection. Here, the left facial nerve is affected in the form of lower motor neuron lesion facial, and here is one part of the body is affected in the form of upper limb and lower limb upper motor neuron lesion pyramidal tract. This is called crossed hemiplegia. Let's go to the other scenario of the internal capsule affection. Also, internal capsule affection, it is above the brainstem level, so it is still above the level of decussation of pyramidal tract. So any lesion in the left part of internal capsule here will be manifested as opposite side of the body weakness. So there'll be upper motor neuron lesion here in the upper limb and lower limbs. So this will be lead to upper motor neuron lesions, the opposite side of the body in left, in right arm and right leg, and there is here affection will be above the level of the brainstem. So the nucleus of the facial nerve is still supplied by the other side. I will give you another slide for regarding the facial nerve, and there will be there will be here an upper motor neuron lesion of the facial nerve, which will be manifested in the same side of the body. This is what's called uncrossed hemiplegia. So if you have a patient with hemiplegia, like here in left side, also here in the left side, check the cranial nerves. If you find the cranial nerve is affected, especially here we'd like to emphasize on facial nerve. Facial nerve is affected on the opposite side of the body. This is number one. And number two, this facial nerve affection is in the form of lower motor neuron lesion, means affection of the nucleus and the down, and the whole part of the face is affected. This is called crossed hemiplegia, and you will reach to the information of the site of lesion is in the brainstem. Okay, if one side of the body is affected by pyramidal tract affection in this right side, and you find there's a facial nerve affection in the same side of the body, and it is manifested as upper motor neuron lesion in the same side of the body. So this means that there is affection of the internal capsule here on the opposite side. I hope this slide to be clear for you, because it can gathering many information in the same time. I can speak here for the facial nerve in details to let it easy for you. We can here imagine that this is a face of the patient. Okay, there is upper part of the face and there is lower part of the face, and there is right side of the face and left side of the face. The line here is to demarcate the face to upper part and lower part. Mostly the upper part you will check about the eye and eyebrow. Lower part you will check the nasolabial fold and the angle of the mouth. So you are usually ask the patient to raise the eyebrow. So we are checking the muscle here and the muscle of face here, and also asking the patient to close the eye firmly and trying to ask the patient to avoid opening his eyes while you are doing gentle trial of opening the eye of the patient. Okay. Here, this can assess the motor power of the upper part of the face regarding the orbicularis oculi and the frontal muscle here of the scalp. Okay. Regarding the lower part of the face, you have two landmarks: the nasolabial fold, if it is lost or it is still intact. If there is loss of nasolabial fold, so there is affection of the lower part of the face. And also check the angle of the mouth. Is it in the same place, or this drop of the angle of the mouth? This is number one. Or if there is any dropping of saliva, this means that this part of the face is affected, so the patient cannot close his mouth intactly, so some saliva is low. And also ask the patient to smile. Show me your teeth. Smile. If he cannot move this part of the face, so it means that there is affection of the lower part of the face. While he can smile of the other side of the face here. So you can see the patient doing like that, smile here. The angle of the mouth is moved here, while here cannot smile. Okay. So in the first impression, you can see that the abnormality is here because the patient muscles here is more powerful. So you can identify the feature of the face here clearly, while you see this flat. But no, don't be confused to know that the lesion of the face is here. No, the lesion in this face is here because this muscle is weak, so this muscle cannot work well. So here there is flattening of the nasolabial fold and loss of the angle of the mouth to move, and there's dropping of saliva, and there is angle of the mouth drop. Okay. All this indicate this lower part of the face. So you have two actions in the upper part of the face and two actions in the lower part of the face to identify which part of the face is affected. Okay. Please raise your eyebrow, close your eyes, and while I will try to open your eyes gently, try to force me, not allow me to open your eyes. If you can open smoothly, so the muscle here is weak. In the lower part of the face, check the nasolabial fold, mouth deviation, smile, show me your teeth like that. And also another action, you can ask the patient to blow his mouth. It means inflate the mouth by air, and try to press by your finger here on the cheek and your finger here on the cheek. Definitely, if this patient has a good muscle here, he can prevent the collected air inside his mouth to go through here. But if there is leak here and the air can go here easily while you make pushing of the cheek here, so this means that the muscle is weak here. Okay. Okay. Let me check also for you that the affection of the face you are concerned about. If you have half of the face is affected, you would like to see if this half of the face, all the half of the face is affected, I mean upper part and the lower part, or it is only the lower part of the face. Okay. Let's speak in details regarding the track of the facial nerve. I would like firstly to emphasize that you following me, and because the link is about to be finished after 3 minutes, so if you would like to yeah, I will speak. So, do you have any question here, or would you like to ask any question now?
Yes, doctor. With regard to the differentiation, like it's upper or lower in the facial.
Yeah.
So you just saying that it will depend on the forehead. You mean?
I will mute and unmute yourself again. Sorry, because there is background again. Yes. Again, your question,
So,
please.
Yes. So, doctor, regarding the differentiation between upper and lower facial,
Yeah.
so it depends on the forehead, you mean?
Yeah, that's what I'd like to tell you now. Here, when you are checking the one side of the face like this, if all side of the face is affected, it's called lower motor neuron lesion. If only the lower part of the face is affected, it's called upper motor neuron lesion. Okay. I will tell you now the anatomy of this tract. It will be easy for you to make it easier. But if you would like to know simply, if I have right side of the face, it's affected in the upper part and the lower part, it's called lower motor neuron lesion in the facial nerve of the right side. If I have only the lower part of the face is affected, it's called an upper motor neuron lesion of the right facial nerve. Okay. I will give you the details later in the next session, because it's about to finish and it will take some time, so I don't like to be interrupted by the link. Okay. So I will close now.
Thank you, doctor.
Send you another link after 5 minutes. Thank you.